Leslie Sidonik. I'm a gynecologist working in the Multidisciplinary Vulvodynia Program here at Vancouver General Hospital. Today I have Dr. Brotto with me.
Hi, this is Brotto, and I'm a clinical psychologist working in the Multidisciplinary Vulvodynia Program as well.
Lori, could you describe what type of women we see in our program?
Sure. So our program is aimed towards women who experience frequent and recurrent genital pain with penetration, a condition termed provoked vestibulodynia.
In our program, we offer a number of different treatments for women suffering from sexual pain, and many of our women are interested in treatments that do not involve medication. Could you tell us if there are effective therapies for women with sexual pain?
Yeah, so among the non-medical or non-pharmacological treatments, there has been some research looking at psychological techniques, and I'll talk about these in a little bit more detail in just a little bit, but the main technique that has been found to be rather effective for women with provoked vestibulodynia, or PVD for short, is a cognitive behavioral treatment approach. This is a rather structured form of treatment that involves a combination of addressing negative thoughts that women have. Very often women will report thoughts such as, I'm not a sexual person because I can't have intercourse, my partner will leave me if we can't have sex, the pain will never go away, and so on and so on. And so the cognitive component of our treatment involves identifying these thoughts and replacing them with more healthy thoughts. A second component of cognitive behavioral treatment is the behavioral component. And because we know that there are often unhealthy behaviors that these women engage in that both promote the unhealthy thinking as well as contribute to the ongoing pain symptoms, our goal in the behavioral component is to identify more healthy ways of behaving. These might include things such as teaching women progressive muscle relaxation, diaphragmatic breathing, and in our program we do a fair bit of work in the way of mindfulness practice.
So it sounds to me like what you're saying is that the way people think about their pain influences the pain. Does this mean that it's all in their head?
This is a common concern that women coming to our program will tell us, that somewhere along the way, either a physician or a friend or they've read somewhere on the internet that because the treatments they've tried have not been effective, the pain must be psychological. The pain is all in their head. The reality is that, pain really is in your head. It doesn't mean that it's made up, though. But all pains are located in our brains. And so one of the reasons why a psychological technique can be so effective is because they directly target sort of our brain's processing of unhealthy information in a way that will decrease stress, that will decrease autonomic output, and in turn reduce pain. So what we often tell women who present with us with the concern that pain's all in my head, we say, well, in fact it is, and it's an unhealthy, or it's an unreal separation between mind and body. The mind and the body work together. And so if a woman is stressed in her life, if she's experiencing depression or other struggles in her life, we often see an impact on her pain.
Does this mean that these psychological techniques would work for other patients with other types of pain?
Yes, absolutely. And here's where we have a lot of really good research that's looked at this topic. Several decades of research looking at psychological techniques for people with other kinds of pains, chronic pains such as fibromyalgia, etc. We also have a fair bit of research supporting psychological techniques in cancer treatment, other chronic medical problems. So this is certainly not something new, using psychological techniques for an individual with a more medical presentation.
Could you explain how stress causes pain?
So again, coming back to the point that the brain and the body are connected, we know, although our understanding of what the factors that lead to PVD are not entirely clear. What we do know is that there's likely some kind of central sensitization process where the brain is misfiring. The brain is misinterpreting touch as pain, and in turn, the brain is sending a lot of kind of excitatory signals down the brain to the spinal cord. So one of the ways that psychological techniques work is it essentially slows down the brain's signals that are traveling from the brain down to the spinal cord. And it's in the spinal cord where those cell bodies of the pain are located.
So what are the physiological changes associated with stress? That's part of this.
So one of the most common ones is an increased output in cortisol. And cortisol is sort of the hallmark stress hormone. If we are confronted with a stressor, if we're in a car accident or if we have ongoing stressors, then the cortisol response is misfiring. There's too much cortisol in the system. And cortisol does certainly play a role in our perception of pain. And this has been found in studies where we compare people who are in chronic states of stress versus not. And those who are in chronic states of stress will perceive a much larger degree of pain than those who are not. So because the repeated experience of painful intercourse in and of itself is stressful, that means each time the woman has that pain experience, cortisol is being dumped into her system, which then further intensifies the pain.
So in layman's term, it's I think people have heard about the flight or fight response. Is that what we're talking about, but on a not just an immediate basis, but going on every day?
Yeah, that's exactly what we're talking about. So there's the immediate effect of touching the genitals, having it be painful, and the sort of immediate effect of cortisol, but it happens on a very long-term basis. And as you know, in our experience in this program, the women that we see tend to have this pain for many years before they have an appropriate diagnosis and get appropriate treatment.
So we've talked about the two aspects of cognitive behavioral therapy. One is changing the way you think, and the other is changing your behavior. Could you give us a little bit more detail about how those behavioral techniques really work?
Mm-hmm. So I'm going to use mindfulness as an example because mindfulness is a technique that's been around for at least 3,500 years in Eastern practice and Eastern philosophy. But over the last few decades, we've seen an increase in mindfulness practice in mainstream Western society. So mindfulness is essentially present moment, non-judgmental awareness. And some equate it with meditation, although it's not quite the same as meditation. What we find is when we actually look into the brains of people who practice mindfulness, and there's been quite a large number of studies looking at this recently, looking at imaging techniques of the brain, something called fMRI. And what we find is that those people who practice mindfulness show different patterns of activation in their brains than those who don't practice. And so the idea is that the person who is in a constant state of stress, or maybe not even constant, just has sort of ongoing stressors, but not necessarily all the time, their brains will fire in a certain way in that it makes it more likely for them to have negative thoughts. With mindfulness meditation, it teaches the brain to fire in a different way. So we talk about this, there's a kind of a fancy scientific name for this called neuroplasticity. But what happens in the brains of those who practice mindfulness is that the brain actually grows in a different direction, in a way that promotes different ways of thinking and more healthy behaviors.
Can you give us a practical example from our patient's point of view, what we're talking about in terms of their negative thoughts and behavior? I mean, I'm thinking of an example. I often hear our patients say that after about 6 months of every time they have sex, it hurts, they start shrinking or avoiding sex. So their partner might make overtures and they're thinking, oh no, I don't want to do this. They try and avoid it. When they're in a sexual scenario, they're thinking, how long is this going to take? It hurts so much. The pain will never go away. Is that what we're talking about?
Yeah, that's a big part of what we're talking about, and what you're describing is anticipation. And so the woman who, suppose she's at home and partner approaches her, maybe partner puts his or her hand on her back, and her thought immediately is, partner wants sex. That anticipation of sex sets off the entire stress response cycle in a way that actually intensifies the pain. And we know this from other research that's found that the anticipation of pain actually leads to an increase in the pain itself. So one of the ways that our psychological techniques can be helpful is for teaching women to come back into the present, to look at the thoughts that they have and say, are these accurate assessments of reality, or are you anticipating something that may or may not be true? Could the touch on the back simply be just that? Or does it have to be an invitation to sex?
That's and what has your experience been with our types of patients, women who are dealing with sexual pain? What has their feedback been after they've gone through? In our program, you hold 3 sessions that are an hour and a half each, teaching them how to reverse their negative thoughts and how to learn some of these stress reduction and relaxation techniques. What's the feedback been from our patients?
The feedback has been that the techniques are very valuable, that women unanimously say that they wish they had learned these techniques, maybe not even necessarily to help their pain, but just in struggles in life in general, but that they can be very, very helpful for helping keep women in the present. And in turn, several of the women have reported that it has had a beneficial effect on reducing their pain. Having said that, another part of the feedback has been that these techniques can be very difficult to learn. And so in our program, we do a 3-session, again, 2-hour per session intervention, but we're really just scratching the surface. And what we recommend to these women is that they seek ongoing assistance after they left the program, whether it's in the form of seeing a professional or reading some kind of self-help book that helps their continued practice with these very difficult techniques.
So our hope is that some of this information will help women who cannot access our program. So where do they turn for help, Lori? Could you describe what type of professionals they should be seeking help from, and maybe if they are any good book resources or online resources that our patients could access?
Mm-hmm. So trained psychological providers in the area of women's sexual dysfunction are rather rare, and they're hard to find. But many of the techniques that we're talking about, these kind of cognitive behavioral principles, there are many more general psychologists trained in the area who can be very, very helpful. So I would recommend to women that they contact their provincial college if they're in Canada, and if they're in the United States, there are state colleges. So this would be like the College of Registered Psychologists in British Columbia, where we are. It's called the College of Psychologists of British Columbia. There's a website, and on the website there's a Find a Provider referral program. Again, if you have the ability to locate a sexuality-trained provider, that can be even more helpful for seeing someone with particular expertise in the area, but that can also be a bit more difficult. Our website, www.mvprogram.org, also has some resources there for helping women find their way into appropriate kinds of treatment. And also we would recommend the National Vulvodynia Association. That's www.nva.org.
Okay, well, I found that information very helpful. Thank you, Lori.
Thank you. It was my pleasure. Hopefully this will be helpful to some women.